Good evening, everyone, and welcome to another session this Black History Month, February, our third webinar talking about Black health and wellness. Today's topic is health disparities among African Americans, and we're going to have a great discussion. And we have this, you see it right there, that powerhouse, this powerhouse panel of guests. Today, I'm going to turn it over to Dr. Philea Lewis, my Executive Director under Family and Community Engagement, to introduce our distinguished guest. Dr. Lewis.
Thank you, Mrs. Fullwood, and welcome to everyone. And we thank you so much for taking time out of your schedules tonight to join us for this very important topic and conversation. And we're really excited about the esteemed panelists that we have. And so I'm glad that I have the honors of introducing them to you. I am going to disengage with the camera for just a moment so that I don't miss any part of sharing of their credentials, if you will. I would first like to introduce Dr. B. Lee Green. He is a senior member of the Health Outcomes and Behavior at Moffitts Cancer Center. He attended the University of Alabama and the University of Alabama, Birmingham, and he earned a degree in joint PhD in public health. Dr. Green has 27 years of practice, and his practice and specialties include cancer disparities and minority clinical trials participation. Dr. Green, welcome. Next, we have Dr. Cherie Pimento Bethune. She is a pharmacy manager at Publix, where shopping is a pleasure. And she has joined us tonight all the way from Ocho Rios. And so we'd like to thank you for pausing from your vacation and your birthday celebration to join us for this very important conversation tonight. She attended Florida A&M University, and she has a degree in PharmD, which is the study of pharmacy. And she also has an RPH, which is the license to practice. She brings to us 26 years of practice, and her practice and specialties include, again, being a pharmacy manager at Publix and being immunization certificated. Dr. Cherie Pimento Bethune, we welcome you. Next, we have Dr. Nancy Andrews Collin, MD and MBA. She is a board certified OBGYN, and she brings to us tonight 27 years of practice. She attended Fisk University, Meharry Medical College, and the University of Arkansas for Medical Sciences. Dr. Andrews Collins, welcome. Next, we have Dr. Tracy Thompson, CEO and founder of Dr. Tracy's House. She attended Georgetown University, earning a BS, Johns Hopkins University, earning an MD, and Howard University, earning an MBA. She brings to us 22 years of practice, and her practice and specialties include Dr. Tracy's House, internal medicine. We'd also like to share with you Dr. Michael Oshinsami. He attended Meharry Medical College School of Medicine. He has a degree in Doctor of Medicine, and he brings to this panel tonight 7 years of practice. And his practice and specialties include anesthesiology. And we also have his other half, Dr. Jamia Washington Oshinsami. She attended Meharry Medical College, and she has a degree in MD and MHSA. And she brings to us 4 years of practice and specializes in cardiology. And last but certainly not least, we have Rose Hornado. Since 1992, Rose has worked in the field of human services, gaining experience and knowledge in community organization, recruiting clients and volunteers, public speaking, program management, overseeing daily operations of state-funded programs, supervising staff, grant writing, developing curricula, and mediation and crisis management. Her passion lies with HIV, where she has focused almost 20 years of her career in HIV prevention and education. To our panel of experts tonight, we welcome you and thank you for helping us to lead this very important conversation tonight. Welcome.
Thank you, Dr. Lewis, for that. And thank you all again for being here. So it's been 15 years since the publication of the Institute of Medicine's Unequal Treatment Report came out, which really synthesizes a wide body of research demonstrating that U.S. racial and ethnic minorities are less likely to receive preventative medical treatments than whites and often receive lower quality care. So I want to pose this question to you, Dr. Oceansamy. Michael, what do you see as some of the many inequities and social determinants of health that put racial and ethnic minority groups at an increased risk of getting sick with diseases and dying?
I think one of the things we have to consider as it relates to that is the opportunities that are in our communities. And when I say opportunities, I mean opportunities for good food. A lot of the opportunities that we come from, we have a lot of food deserts. So a lot of times these food are high in salt, high in sugar. And so as a result of that, we see a lot of subsequent diseases in our communities, such as diabetes, hypertension, again, as a result of the increases in the sugar in our foods that we eat as a result of the food deserts, and the increases in the salt in the foods that we're eating, thereby, again, resulting in high blood pressure. So I think it's important to, again, realize the options that we have available to us for nutritious food as it relates to health disparities in our communities.
Okay. Anybody else want to add to that?
I think differences in healthcare accessibility, and the use of care and the quality of care that's seen, that causes a huge disparity as well. Education and socioeconomic has also led to that. Studies have shown, and I know when the when the Affordable Care Act came out, it did close the gap somewhat in the coverage, for health insurance that we saw, but there's still a long way to go that we need to do to get education out there, to get accessibility to healthcare, and as Dr. Oceansamy suggested, getting lifestyle changes as far as nutrition and good food and diets.
Mm-hmm.
And I think also there's the structural and institutional racism that it's long plagued the healthcare system, just the biases in terms of presentation of certain diseases and conditions. And now we've seen sort of the drive of cultural competency and the ability to sort of close the gap between the patient and the physician, and trying to make sure that there's a level of cultural competency. So I know that that's with medical school education, but there are some, older generation didn't have that type of training, and being able to close that divide, and seeing that it does take a lot of concerted effort to break down some of those institutional barriers that still exist.
Okay. Do you all see maybe like even with distrust, from historical events such as the Tuskegee study, do you all see that in your practices when you do see patients that maybe they've taken a long time to come get seen and they were hesitant to even go get those screenings or whatnot?
Yeah, I that is an area that I've done a lot of research on. As a matter of fact, I wrote one of the first papers looking at the impact of the syphilis study on individuals, participating in clinical trials and research studies. And just like what we found, there is still quite a bit of distrust of the medical system, distrust of the government, and obviously we continue to see that today. And so we as institutions have to bridge that gap between who we are and connecting with the community. And so there are many of those things that we're trying to do at the Moffitt Cancer Center, because we're not immune to that as well. We know that there are people who still don't trust coming to a place like Moffitt, and in some cases feel like Moffitt is not a place where they can come and get their cancer care. But we're working very hard to try to break down some of those issues. But it's still a major issue.
All right, so thank you for that. And since we're talking about Moffitt, I'd like to start a little bit off with each of your specialties. So let's go ahead and start with cancer. So between 2009 and 2012, data shows that the incidence of breast cancer is slightly lower among African American women, but the mortality rates were worse. Is this still true? And if so, why do you think that is true?
Yeah, let me just start by saying very quickly, it is absolutely true. And let me back up and say that, this is an incredible time in terms of cancer science, in terms of medicine, research discoveries. A lot of that, is happening at Moffitt. This information is being translated into, better approaches, new therapies, detection, treatment, all those types of things. But to your point, there's still this grim reality that the progress that we've made is still not benefiting everyone equally. And you mentioned the situation with Black women. It's still a huge issue. And there continues to be certain segments of our population who still shoulder the disproportionate burden of cancer. And breast cancer is one of those areas. Prostate cancer is one of those areas. And specifically around breast cancer, one of the things that we do know, so white women get breast cancer more often, Black women die at a higher rate. And you think that's just unacceptable. How in the world does it switch like that? But what ends up happening is that Black women tend to be diagnosed at a later stage. So although the rates are lower, when they do come in to get their care, they are at more advanced stages. And by the time they get to that point, the survival rates tend to go down. And so part of what we have to do as a profession, as a community, is to make sure that we get women in to get those the mammograms, to get their screenings done as soon as possible, because we all know that early detection is absolutely the key. And I think that's the case for all cancers in our community, making sure that people are well educated in terms of when they need to go in and get their screenings.
Okay. And also, so since we're on that, there are racial disparities in treatment outcomes for young colon cancer patients. And it appears at every stage of the disease, and data shows suggesting screening access isn't all that matters. And is that true? And why do you think that is?
Yeah, I think that is a part of the issue, but I think it also goes back to the whole notion of education. And understanding what the risks are, and making sure that people, that we're getting the information to the right people in the community. One thing that's a little bit alarming is that we're starting to see younger people coming in with colon cancer, which is certainly very disturbing. And so we've got to do a much better job of getting that information out into the community.
Okay, so what are some things that we can do to stop that upward trend of breast or colon cancer?
I think it goes back to education and screening. Screening, I think, is the key, and particularly with colon cancer, because it's one of those cancers that you can prevent, almost immediately. If they go in, you do the screening, they see a polyp, they can take it out immediately. And that's one of the few cancers where we can do that, where we can address it immediately. But what we're finding is that people are not going in to get those screenings. And that's something that we've got to work on more aggressively, not only as a cancer center, but as a community.
And so what is Moffitt doing specifically to address Blacks and cancer?
Great question. One of the things that we are doing, because we know that research is so critically important, we have a program that we started several years ago called the George Edgecombe Society. And the purpose of that society is to raise dollars specifically to address cancer in the Black community. Many of us are familiar with George Edgecombe, who is a very good friend of Mr. Moffitt, who is the creator of the Moffitt Cancer Center. And because George Edgecombe ended up having to go to other parts of the country to get the care that he needed, we didn't have a cancer center in the state of Florida. So that's how the Moffitt Cancer Center was created. And so, how appropriate for us to now raise dollars to address this issue within the Black community. And so up to this point, we're up to almost $2.5 million that we've raised to address cancer specifically in the Black community, something that we are very, very proud of. And again, still have a lot of work to do in terms of raising those dollars.
Okay, thank you for that, Dr. Green. All right, Dr. Jemiah Oceansamy, I would like to turn this over to you. Heart disease. Heart disease and cancer, of course, we talked about, are the leading causes of death across race, ethnicity, and gender. African Americans were 30% more likely than whites to die prematurely from heart disease in 2010, and African American men were twice as likely than whites to die prematurely from a stroke. The CDC, the U.S. Centers for Disease Control and Prevention, reports that nearly 44% of African American men and 48% of African American women have some form of cardiovascular disease. Can you give us some insight to this as to why
there's a disparity?
Yes.
I think it kind of goes back to the discussion that we were talking about earlier with the social determinants of health. From my experience, I see a lot of patients who may not have the knowledge. A lot of that is tied into lack of education, lack of resources, like Michael was saying, food deserts. All of those, you know, when we look at these numbers, we're like, oh my God, why is it so high for African Americans? But all of this is all related. It comes down to a lot of like socioeconomic status, things of that nature. And a lot of times, like for me, when I see patients, you know, it's evident that there just may be a lack of knowledge, or there's a lack of resource, or lack of transportation to the doctor's office. It's things of that nature that contribute to those numbers,
Okay.
especially in the African American population.
Okay. So what are some signs that one might be experiencing some heart issues? Like, what are some signs?
Some clinical features. So,
yes.
I've seen a lot. So, you know, a lot of times you look on TV and advertisement is like a guy clutching his chest. That's rarely ever the case now. For me, being that I'm specializing in advanced heart failure transplant, a lot of our patients come in with shortness of breath. They come in with swelling in the lower extremities, weight gain. Some patients may not have lower extremity swelling, but they may have swelling in the gut. So a lot of questions that I ask patients is, how does your pants fit? Can you still wear the belt that you've been wearing, I don't know, 5 years ago? How does your clothes fit? Because that water, basically you're retaining water, either in your legs, your stomach, in your gut area. And so those are some of the symptoms. When we think about things like heart attack, that's what they display a lot of times on advertisement. Like I said before, they'll show someone grabbing their chest. Well, for women usually have what we call atypical symptoms. So may not have the chest pain, but they may have stomach pain, or they may have neck pain, or they may have shoulder pain, or they may have, what's another one? Instances where they passed out. So the symptoms can be very different in people. I've seen people come in with jaw pain and be actively having a heart attack. So, you know, I tell people when something is abnormal, really abnormal, you need to seek help. And so just depending on what the symptoms are, a lot of heart failure symptoms, like I said, a lot of times it's shortness of breath, or symptoms like, you know, a month ago, I could walk 100 feet and not get tired, but now I walk 100 feet and I'm about to pass out. You know, something's not right. So the clinical features are very different, and it's not always the chest pain or someone grabbing at their chest. It could be a different variety of symptoms.
So I want to veer off from what you were saying, because about the trust, because, you know, some people look down on those, you know, in our community. We look down on those.
Yeah.
Like every time your little finger hurts, you want to run to the doctor. You know, we kind of talk like that in our community. And so what you're saying is, no, when you see something that's different, seek help. Is that pretty much the message there?
Yeah, you know, for example, like, I know what a normal headache feels for me, right? But if that headache is to the point where I can't like see, or my visions, you know, is bothered, or it's just abnormally painful, you know, you need to get to the hospital. You may be having a stroke. And the same thing for, you know, when it comes to like cardiac disease, you know what a normal back pain is for you. But if that back pain is so severe to the point that you can't stand, or it's impinging on your, like it's impinging on your functioning, then something may be going on. You know, it may not be the normal osteoarthritis, or, you know, whatever the case may be. It may be that you're having a heart attack, or you may be having some other cardiovascular event that needs urgent, immediate assistance. So, you know, I think that's important too. Speaking of, you were asking me insight, why? That is it too, because sometimes we try to diagnose ourselves, or we think, oh, this is just back pain, or this is just shoulder pain, and that can be a heart attack. So I think all of those things come into play, and I think, you know, it's important that we, you know, we try to get that information out to the public, that it's not all about just me grabbing my chest, having a, you know, excruciating chest pain, because it's different presentations.
All right, thank you for that. So are you seeing less African-American patients being treated like ahead of time, or are they coming in once they have the problem?
So, to be honest, I'm seeing, when it comes to our African-American patients, a lot of times I see them when they're like, I take care of really sick patients, but as far as my African-American patients, their care is delayed a lot of times. They haven't had follow-up, or they may have had follow-up and then they were lost to, you know, follow-up for whatever reason. Compliance, you know, unfortunately is usually a main issue. And so usually by the time that I see them, they're really sick. And unfortunately, it's to the point where, you know, sometimes we can't help them. And then sometimes, you know, we do our best and we can help them with their advanced care. But a lot of patients, African-American patients, I usually see them delayed. Okay.
And so what are some preventative measures that they can take to not get for you know, I know we're talking about food deserts and not eating healthy. I guess once you're diagnosed, what are some things? I guess, Dr. Bethune, are there different types of heart medications? But besides the medications, and I know eating right and exercising is important.
Well, that's what I was going to say. There are factors that can contribute to heart disease. Age, family history, your diet, exercise, cigarette smoking, alcohol intake. The things that we can control is what I perpetuate to my patients. I mean, we can't change father time. Obviously, we can't change who mom and dad are, but we can change the way we eat, you know, having a healthier diet and decreasing your salt intake, maintaining a healthy weight. Those things that we can control, we can start there. As far as medications, there are medications that are out there specifically for hypertension that too plagues our community. There are like 4 classes of antihypertensives, 4 or 5, but experts have shown, or studies have shown, and experts have recommended that in African Americans, we tend to do better with diuretics and with calcium channel blockers, such as amlodipine. But we can also use beta blockers and alpha blockers and things of that nature in combination with these drugs, but we tend to respond better to those type medications.
Okay. Is there a reason why?
But no, and I know that Dr. Ocean Sami, she can probably explain it a little better, but it's because of the low remnants that we have just genetically. African Americans tend to have a low renal state and a lower cardiac output. And she can probably speak more to that on why we respond better to those calcium channel blockers.
Yeah, and like she was saying, diuretics and calcium channel blockers are more, African Americans, we are more responsive to those. What some of the studies that I've seen like in the past was that, at least for African Americans, we are usually more salt sensitive. And when you're looking at not to get too deep, but when you're looking at the mechanisms, specifically speaking about the diuretics, it helps with that process along the chain of events that happen. The physiology of it, diuretics, we respond better because we're more salt sensitive.
When you say salt,
diuretics are like water pills.
Yeah, basically water pills. Yes, I'm sorry. Okay. So that's like your I know some people out there may like HCTZ, hydrochlorothiazide, chlorothalidone. Those are all diuretic medications. And for people, so my specialty is advanced heart failure. So I see a lot of people with heart failure, and the water pills are very important for those patients. And that has a lot to do, not so much with the salt sensitivity, but more so with the congestion. It helps, because it's a water pill, you lose water. So, you go to the bathroom a lot to like urinate and things of that nature. And then also the calcium channel blockers, as Dr. Bethune was saying, calcium channel blockers is more so a different mechanism than like the angiotensin system. So, which we have a lower response to. And so calcium channel blockers are the medication is like amlodipine, or people know it as Norvasc. I know some people may take that medication. Those allows for our blood vessels to kind of dilate, and when your blood vessels dilate, there's more flow through that area. So those are more so, I know for me, when I see my patients for the first time, especially starting them on antihypertensive, I go to the diuretics and then I go to the calcium channel blockers. Those are my first go-to, especially for my African American patients.
Okay, thank you for that. So let's talk about stroke. Did anyone have, I thought was someone else going to say something? I don't want to rush.
I want to say something real quick. I just want to say it's really important what Dr. Bethune and Jamil were saying, just in terms of knowing that those are the types of drugs that work in our community. So if you see your mom or your dad or your sister or your husband or whoever, it may be your relative on medications that are not those, antihypertensives that are not those, and you know that something is wrong, they need to be on something else. So make sure you double check with your physicians, or if you know other people in the medical community, you can double check with them just to make sure they're on the right medications that are working for them. So I think it's really important to know those things.
That is important to know. Thank you for that. Thank you for that. All right, let's move to strokes. So stroke is the third leading cause of death in the African American community for African Americans between the ages of 20 and 44. The risk of stroke is nearly 2.5 times higher than it is for Caucasians. And so African Americans have more severe strokes that are also more disabling. I don't know who could answer this one regarding strokes. Why is this, and what are some risk factors? Go ahead.
So looking at some of the risk factors, it's high blood pressure, it's diabetes, tobacco use, the same, the stroke is caused, it's cardiovascular, so same risk factors for, heart disease can cause stroke. The stroke could be because of clogged artery, but it also could be a blood clot that moves from the heart, goes to the brain, and causes not enough blood flow to that area, causing a stroke. So those are some of the sort of risk factors. And the thing about, similar to a heart attack, knowing the signs and symptoms of a stroke, and being able to go to get treatment as soon as possible, because there are some clot busting drugs out there that can be given, but it needs to be given within a very short time frame of the onset of symptoms.
Okay, so let's talk about those symptoms, and let's talk about some of those symptoms. What are some symptoms of a stroke?
They could be, who are you, me or someone else?
Yeah, Either one. Mm-hmm.
Okay. It could be loss of speech, mumbling speech. You could have a thing out. It could be a sudden numbness or weakness in one side of the body. And again, it's usually that numbness and loss of feeling in one side of the body, or, drooping facial muscles and things like that. It also could be blindness, anything that is affecting typically one side and not the other. Suspect that it could be a stroke.
Okay. And what are some, Dr. Bethune, what are some treatment? Talk a little bit about the medications used after a stroke.
After a stroke or post-stroke, patients typically are given blood thinners, anticoagulants, and or antiplatelet drugs. And it depends on what type of stroke. As she mentioned, is it one like an ischemic stroke, or one a hemorrhagic stroke, the blood clotting, if you will. So you take anticoagulants or blood thinners, such as aspirin or dipyridamole. Those are the things that will help to that. But can't talk about those meds without talking about some of those other underlying heart diseases, such as hypertension and high cholesterol, because those type disease states can contribute to the stroke. So having hypertension, cardiovascular disease, high cholesterol, diabetes, those things, and they deem that as metabolic syndrome. Having those three together can lead a higher cause to having stroke. So most patients are screened at the time. So not only taking the blood thinners, getting them on something to help decrease their high blood pressure if they're experiencing it. I've even seen patients who may not have high cholesterol. The doctors may even start them on a cholesterol therapy because, again, they can contribute to having strokes as well. So aspirin and those blood thinners are the to answer the question regarding post-stroke meds that you start on and take them continuously, but also treating those other underlying heart diseases.
Okay, so let's get right into, go ahead, I'm sorry.
And I just, and I want to just say this, especially for the people listening, when I see people and we're talking about preventative care, stroke, heart attack, diabetes, all of those are related at some point. Like Dr. Bethune said, high blood pressure, high cholesterol, all of those things can cause a stroke. They can cause cardiac disease. They can cause what we call peripheral artery disease, where we have blockages in the lower extremity. And so when I speak to my patients and I'm talking about preventative, I always link those three together: stroke, heart attacks, and peripheral artery disease. And what I tell them is a stroke is so they can understand, it's not literally the same thing, but a stroke is basically a heart attack of the brain. So that just means that your brain is not getting the adequate enough oxygen, whether it's a hemorrhagic stroke, you bleeding, or it's a thromboembolic stroke, or whatever the case may, ischemic stroke, your brain isn't getting the oxygen and the blood flow that it needs. The same thing for a heart attack. Heart attack is nothing but the heart not getting the blood flow that it needs to carry in the oxygen that your heart needs. And the same thing for peripheral artery disease. When you have blockages in your lower extremities are not getting the blood flow that it needs that's carrying the oxygen. So the mechanism, and that's why it's all called cardiovascular disease, whether it's in the brain, the heart, or the lower extremities, it's the same concept. So whatever contributes to that lack of blood flow, the blockages, you're going to either get a stroke. If it goes to the brain, you're going to get a heart attack. If it goes to the heart, and then you'll have peripheral artery disease, potentially, if you have some type of blockage there. So the risk factors are the same. So you treating any one of those disorders along that spectrum is the same. So you want to try to prevent that doing the same exact things: controlling your blood pressure, controlling your diet, controlling your diabetes if you have diabetes, controlling your cholesterol levels. And so I just wanted to say that because it's the same concept when you think about it.
Okay, well, thank you for that. Thank you for making that clear, because that did shed light on me. I wanted to go to Dr. Thompson about diabetes. I'm going to give you some data. So in underserved and minority communities in the U.S., diabetes is amongst the most prevalent of the chronic diseases. More than 18% of all African Americans over 20 years old have been diagnosed or have undiagnosed diabetes, as close to 12% of Hispanics in the same age group have been diagnosed with the illness. And despite the disproportionate number of cases, studies have shown that Hispanic and Blacks people with diabetes are 2 and 3 times less likely to, get the treatment that they need. Can we first, before we start, talk about the difference between type A and type B diabetes? What's the difference?
Yes. So the first type of type 1, that is usually in children, and that's when they don't make any insulin on their own. It's usually because there's an immune response or antibodies to the pancreas that makes your own insulin, so they can't make any insulin. So they need to be on insulin, and usually happens when they're young.
Okay.
Type 2 is when your body gets to a point, basically your pancreas gets so tired of working too hard, it just poops out. And you get to this point where you first have insulin resistance, so your body doesn't respond to the insulin, and then it just stops. So that's why we can start for type 2, depending on when they can catch it, they can start on pills first. And then if it gets to a point, it may require you to be on insulin. So usually type 1 are children and they need to be on insulin. And then type 2 is one where you usually start insulin resistance. But then if it's untreated, it will get to a point where you have to use, external insulin in order to have because what the insulin is doing is making sure that your cells get the sugar it needs to function and work. So that's the insulin helps drive it so that it's like the currency that it needs in order to do everything.
Mm-hmm. Okay. So, and the mostly treatment for diabetes is insulin. Are there other?
There's different medications now. Dr. Bethune can jump right on in. Yes, but she can jump right on in.
Well, there are the goal of all the treatments is to help the glucose be controlled in these patients. And in the type 1 diabetic patients, insulin is their only treatment option. Type 2 diabetes patients, there are oral meds that are out there, and they have different mechanisms of actions, if you will, on how they treat. Some help the pancreas produce more insulin, and some help the way the carbohydrates break down in your body. But there are oral meds, and they can be used in combination in patients for type 2 diabetic patients, in addition to watching their weight and with proper exercise. Now, if they aren't controlled, and if you see these insulin levels still be elevated, then you will add insulin to their therapy as well. So there are different medications out there, both oral and the insulin.
Okay. So once someone has diabetes and is on insulin, is that for life? Is that the rest of their life? Can someone come off it? Do they get better?
In type 2 diabetic patients, that can be, a thing where they can get off. And the goal is to try and keep those patients who are on oral meds, on oral meds, and not have to get them to, the point of using the insulin. Again, that's where the weight control and salt intake and your nutrition, that's where all of those things come into play.
So the same type of preventative measures really is really lifestyle, basically.
I mean, those lifestyle changes will, as Dr. Washington, no, I'm sorry if I'm saying that improperly, but as you mentioned, I mean, that's going to go across the board of both, diabetes, high blood pressure, stroke. All of these are controlled, or these factors contribute, as far as lifestyle changes. Mm-hmm. And maintaining, as not a sedentary lifestyle. You want to get out and, increase your physical activity, and make sure you, have a better optimal diet, in cases like that. And then just, smoking cessation, alcohol intake, all of these things are going to help those cardiovascular diseases go down.
So we talk a little bit about trust, you know, with African Americans and going to the doctor. So what if one is going to the doctor and they've been diagnosed with diabetes, what are some things that they can do to better advocate for their care? Like you all mentioned, specific medications for heart disease. Is there something that a patient who a diabetes patient, what can they do to advocate, just like with the other diseases?
I think it's to know your numbers, your hemoglobin A1C, and that's a blood test that shows how well your blood sugar has been controlled over your 3 months period of time. Really, and it is a lifestyle change. If there's someone in the house who is a diabetic, in order for them to adhere to the diet that they need to, the meals prep, it needs to be, they need to have that support at home. So having someone that is there, that understands what types of carbohydrates they should be using, portion control, and it really is, really becomes a family affair in order to ensure that they stay compliant. Some people don't like to take their blood sugars or check their blood sugars, but there's other things out there. There's like you said, the technology out there that, depending on what they can do, they can have it, their glucometer that is, attached, and they can use their smartphone in order to check their blood sugar. So these are just things that they should just know, but the key is to know your number.
Okay. All right. Thank you. All right. I want to move to HIV and AIDS. This is another disease that is killing African Americans. So the outcomes for HIV, the magnitude of African Americans and white disparity is acquired. Diagnosis mortality has actually grown. I mean, it's been a long time since it first started. So I want to go to you, Ms. Rose. Can you give us a little insight on this and what has been done to overcome this uptick?
Sure. So we know we're 40 some odd years into the epidemic. In around 88 is when the new transmissions in the Black community exceeded the white community, and it hasn't really changed since then. We've been disproportionately impacted for well over 30 years. There's lots of different reasons that can be recognized as barriers. Stigma obviously is still attached to HIV. We don't have as easily access to care as other communities. And culturally, I think there are a lot of barriers. Socially and structurally, we know historically we've had some distrust in the medical field. And so there is a definite need to have a little bit more cultural competency when it comes to HIV education and prevention. There are lots of community-based organizations that go out into the communities, but we need to see, I think, a little bit more consistency. We need to see a lot more folks out into the community being much more visible, making sure that we're breaking down those barriers that continue to stigmatize us. Make sure that folks are understanding what the local statistics are. Like in Hillsborough County, for example, 44% of all new HIV diagnoses are in the Black community. Yeah, even though we're only Black men who have sex with men. And so that in itself speaks to a lot of the stereotypes that are still perpetuated, within our communities. And the prevention efforts, the things that are updated that we aren't really aware of, where not enough people are understanding U equals U, that being untransmittable, if you virally suppress, you really can't transmit the virus. The updates in treatment in regards to PrEP being a preventative measure. Treatment as prevention, as I said, you equaling you. All of these updates, I think, are necessary, and this education needs to be consistent. But it also needs to be people who are representative of our community, who are out there on the forefront.
Okay. So, Dr. Bethune, I want to ask you about medications for HIV and AIDS. What are they and what do they do?
There are like 30 plus drugs. They've made wonderful strides in medications regarding HIV. Years ago, if a patient who became positive, HIV positive, they could take 15 to 20 drugs per day. And it is a daily thing. You have to be extremely compliant with it. The drugs now, you have these combined drugs or drugs that may have two substances in one pill. So patients are more compliant, they're living healthier lifestyles, and the viral load is becoming undetectable when taking these drugs. There are about 7 drug classes. I won't get into it because it's more medically concerning, but there are medications that are out there that's not curing AIDS or HIV, but it certainly can get the viral load to be so very undetectable that they can live very normal, healthy lifestyles.
Okay. And so Ms. Rose, what do you think can be done more to help lower the cases of, African Americans being diagnosed and that mortality rate? What do you think what do you see in the industry can be done more?
Well, I think we as a culture need to normalize these conversations. What we're seeing is that the more people that are getting tested and know their status are getting retained into care and then getting virally suppressed. So the folks who don't know their status, who are not getting tested, who are staying undiagnosed are really the highest at risk of transmissions. And so I think we normalize these conversations around getting tested, about getting onto treatment as quickly as possible, because the quicker you get onto treatment, the quicker you can suppress your virus. Making sure that folks understand it's not a death sentence. People are actually living a lot longer and a lot healthier living with HIV because of the advancements. And, just making sure that we are not furthering the stigma attached to it. Historically, I've been doing this work since 94. I started volunteering in 92. And I wish that we could get our communities of faith on board with this. I think that would be the catalyst to change for us in our Black and Brown communities. If we can get the folks who are the leaders in our faith-based, communities to coincide with us in this movement. There are a few, but there aren't too many. They're very fractured, and we really need to have a united front, because I feel like they are some of the strongest gatekeepers in our communities and hold a lot of leverage and power. And so if we can get them behind this movement, I think we could really, really see a change.
And so your organization does a lot with, information. I know there was an event tonight, I believe, that they're having. What do you all do?
Yeah, Metro Inclusive Health work. That's how it was founded.
Okay, thank you for that. All right, so let's move on. Dr. Andrews Collins, our OBGYN here. So this is a very disturbing statistic I want to talk about. Black women, we are 3 times more likely to die from a pregnancy-related cause than white women. What are some factors that contribute to these disparities?
Just as everybody has been speaking of, one of the biggest issues is that we aren't taken as seriously when we come in. Mainly because pregnant women have a tendency to be younger, and unfortunately, a lot of labor and deliveries aren't very large places. They may only have like 14 or 15 beds. And they just aren't taken as seriously. But a lot of the cardiovascular things that we've been talking about, ours are more significant. People haven't looked into the fact that everybody in the family is hypertensive. 2 or 3 have already had heart attacks. Why do you think that this lady is not going to be a setup for this? Because genetics is one of our biggest reasons for having all of this, and you can't really change that. But the younger that they are, the less likely they are to take it seriously, because they think, I'm young, I can do whatever I want to do. And they don't take it seriously, and unfortunately, it's a big thing. But the disparities thing is that when they come into the triage area, they aren't taken as seriously as other races. When they have complaints of, my hands are numb, or, my face is weak on one side, I can't chew, I can't swallow. They just think that they're just there for, some sort of social visit or something. And then the other thing is Dr. Jamia, I don't want to try to say your last name, is that a lot of the Caucasian doctors don't understand. They don't really like to use water pills in pregnancy, but for the African American girls, you're just going to have to suck it up and monitor them a little closer. But they really do not want to put them on diuretics when they're pregnant, because the baby's not necessarily hypertensive and they got developing kidneys and yada, yada, yada. So I understand that, but at the same time, you got to keep the mother alive to get the baby here. So, it's one of those things where it's a little bit too much generalization, and you just have to kind of look at it and see that, we're just going to have to maybe do a little more work with her and make her come in a little more frequently. And that's one of the things, is because they're already hypertensive. I tell them, you're 25 years old. When you put a baby on board, it's going to show you everything that's going to happen to you when you get older. If your hypertension goes up and you turn out to be diabetic, we're supposed to test them 12 weeks after the pregnancy for the diabetes, because that's a sure sign that you may already have been diabetic. But if you don't come in till you're 25 weeks, who knows? I mean, we got 2 people on board now. So those are some of the things, but the disparity is that they are not taken as seriously when they complain about symptoms. And then things happen so rapidly, it's like, oh my God, I didn't realize that. And I mean, sometimes they've been in the hospital a couple of weeks, because we keep them in the hospital sometimes, because it's like, she's not going to do good when she goes home. We've already tried that for 2 weeks. Every time she comes back, she's worse. We're just going to have to keep you on lockdown. But sometimes that still doesn't work. They'll still go outside and smoke. Or somebody will bring some alcohol into them, Wow. We don't really know what that is, other than they just don't take it seriously until things start going downhill. And when you got that second person on board, it can go downhill pretty fast. And I'm sure Dr. Jamia's husband knows, because he's anesthesia, because they have to come in and help us a lot. So I mean, it gets to be really interesting. My sister is an anesthesiologist, so she's just like, oh my gosh, it's just out of control. But everything that everybody's talked about, half of my patients are young, and they're the exact opposite from Dr. Jamia's patients. They're young, they're vibrant, but when you put that second person on board, it starts giving you these flashcards, like, when you get older, this is what's going to happen, because your system, when it's stressed, this is what it does. And as they get older, you see it happening, and you just have to stay on top of it. I came from a rural state. I just came back to Tampa, but I can tell you, just like with the breast cancer thing, it's fear. My best friend, who is African American, is the head of breast oncology at the university I just came from. she's African American, she's from a rural town, and it's fear. It's like, you know good and well you should not have this ulcerated lesion on your breast. It's like, why did you let it get this far? You know, but it's fear that, and then they'll come and they'll say, oh, I didn't notice that. How do you not notice that? So anyway, that's my take on all that we've talked about, is we are not taken as seriously in most situations until it gets to the point where the ball is rolling downhill and we hope that there's enough people to catch us, versus taking care of it on the other side when you can do the insulin and the medications and that sort of thing. And one of the other disparities I want to say is that insulin, as long as people have been taking insulin, it's one of the most expensive drugs I've ever seen that's been out since what, the 50s, 60s. I have a cousin that's in her 70s and she's been on insulin that long. But I have so many patients that can't afford it. They can't afford the copay. They can't, you know, but you know, we get all the stuff that we can get for them. But you know, we also have the fear factor of, we don't want to stick ourselves. We don't want to give ourselves the shot. And nobody in the house wants to look at a needle like it's like, it's like, but you got a big butcher knife in there that you use every day. So, I mean, I just try to make, you have to try to make light of the situation without making too much light of it.
Yes.
And a lot of things are around fear. When you really talk to them about, why are you not doing what I'm asking you to do? You know, you can die or your baby can die and you live, that's even worse. But so, you know, that's my take on all of it, is we have a lot of fear, but a lot of times I just tell them, just look at the people in your family. If you know them, you're going to be more like them than the rest of the world, even if you're African American. It's not rocket science. If they all are hypertensive, yeah, we need to keep watching you for that, because you're going to be more like them than the rest of the world.
So to your point, I want to ask this question. It was actually asked in the chat. How important is that doctor-patient relationship to getting patients to follow up with, to follow treatment and follow up? How important is that doctor relationship?
I think it's very important, because some of my patients that I know are, fear is a problem for them. It just means so much to them if I just call them on their phone, like a day or two later, and say, okay, did you go and get that medicine that I gave you? You know, I just talk to them like a regular person, not like, oh, this is, I was like, no, you know who this is. I give them my cell phone number.
Wow.
It's like, did you go and pick that medicine up? Have you started taking it? It doesn't do any good sitting in the bag, you know. So those things are, to me, it's very important to get people, especially African American patients. I mean, I do it for all of my patients, but you can see the fear in their face. Or every time that they come back, it's like, why is your blood pressure 190 over 110? That's just, we talk about this every time you come in here. It's like, yeah, I'm gonna have to send you to the ER because I can't really do anything with you today. You need to go get your blood pressure down. So it's like, no, you're not going to work. Sorry. And it's like, do I need to call the ambulance to make sure you actually go to the ER, or are you going to go on your own? So, I mean, when you show care for them, they have a tendency to listen to you more, and they have a tendency to come back.
So speaking of care, you know, representation matters. It takes a combination of care and culture and social, societal understanding to create that critical, you know, formula for quality patient care like you all give. And part of that understanding for medical teams is knowing how diverse representation and, you know, can really impact certain patient populations. Just going back to that trust. So it helps to have representation from all communities and within all the medical disciplines, all medical fields. Harvard Business Review reported Black Americans make up only 13% of the U.S. population, but only 4% of U.S. doctors and less than 7% for U.S. medical students. And as a final closing for you all, I'm going to go through all of you all. So while you were in school, did you, while you were in medical school, why did, okay, so this is a two-part question. I want to know why you went into the discipline you went into. And when you went into that particular discipline, like, were there a lot of African Americans in school with you in that particular field? And then part two of that, I just want some personal experiences. What can be done to build that trust? Your opinion about what can be done to build trust among sisters and brothers to seek early diagnosis and treatment. So that's a loaded question, and I can ask it over. So I'll just start at the top with Dr. Bethune.
Well, I went to an HBCU. So as far as not being encouraged, I did not have that problem while in school because everybody looked like me. So there was absolutely representation. Similarly to doctor and patient relationship, we had an opportunity to have that student professor type relationship in an HBCU setting. So I didn't experience it while in college, but I remember in high school when my GPA was high. I had already been accepted into Florida A&M. My SAT scores were subpar. I had only taken it one time. And when I went to go sign up for it again, my guidance counselor at the time discouraged it. And I remember that. And because his thing to me was, oh, you already accepted, why would you take it again? And so as a student, I'm thinking to myself, well, he's right. You know, you really may not want to take it again. I was accepted, but what it did, it hindered me from getting scholarship opportunities that required a higher SAT score. So that was the only thing that I can recall as far as my personal experience. As far as, you know, my want to be a pharmacist, I just always wanted to be in the healthcare profession. And I just feel I'm in my purpose because you are helping patients. You are creating better lifestyles for these people. And so it's something that I've always been passionate about. It started off in medical, and I think I geared it toward pharmacy by the time I graduated from high school. I have a wonderful mentor as well, who is a pharmacist. And I think he was on your panel maybe last week, Dr. John Scrivens. So those were the things that helped propel me to go into the career choice that I've chosen.
And so what do you think can be done to build trust? Sort of like what Dr. Andrews Collins does with her patients. She gives them her cell phone number. She calls them. She checks on them. She threatens them. Like she's doing everything. What do you think can be done to build more trust in our community with physicians?
I think education is the key in programs, panels like these. We just have to get people more involved in understanding these situations and screenings that was mentioned earlier. You know, getting these people screened. So you know, prevention can be a thing as far as, you know, we won't get to that high blood pressure status if we're living these proper lifestyles. You go get your mammograms or having these colonoscopies done to help prevent that things that can happen in the future. As far as trust, you know, building these relationships between your you know, with your patients. I know even on a pharmacy level, I don't give up my cell phone number, but I certainly do call my patients and follow up with them and have these you know, very authentic discussions. You know, why haven't you gotten your meds, or you know, putting them on some type of 90-day you know, plan where they can be compliant and ensure that they're getting those. I'll even call to find out, you mentioned, someone mentioned about the cost of some of these meds. I'll even call manufacturers and get manufacturer coupons to help offset these costs and things of that nature. So I build these relationships with my patients to ensure they're getting optimal care as well.
Thank you for that. Thank you. Dr. Tracy Thompson, same question. When you were in medical school, why did you go into that field, and were there a lot of African Americans in your school?
So when I went to Hopkins, inner city Baltimore, all my patients looked like me, but I didn't see the representation in as professors or the like. But my mentor was a very strong, she's still there, Dr. Lisa Cooper. And she was an internist, and she's still doing health disparity work and health equity work at Hopkins. And so that's why I went into the field. But it also, talking about the building the trust. I mean, talking with the patients, you have to be real. I had a lot of intravenous drug use during that time. I saw all the complications of AIDS because people weren't going and getting the access that they needed because of drug use. But I'm having those conversations and, being able to talk to somebody while they keep coming in with hearts. Like, what do you season your greens with? No one's asking, what do you season your greens with? But if you're doing, ham hocks and talking about, but that's the salt in it is causing the greens, is causing you to go into heart failure. And that's why you keep coming to the hospital. So it's that cultural competency of having those real conversations and encouraging and things, what can we do, is encouraging men and women, kids, to go into the sciences, to go into medical school, to continue that pipeline of individuals so that people, when they go to the doctor, because that's what they want to see someone who looks like them, who may have had similar experiences, and then they're more able to trust them, to follow their advice, because we're going to talk to them like I'm talking to my sister or brother.
Thank you for that, Dr. All right, Dr. Green, same question. Why did you go into your particular field? And while you were in medical school, did you see many African-American students?
Yeah, so you all allowed a PhD to sneak in on this panel. So I'm on the other side. I'm a researcher. And so I appreciate that. And so I had a grandmother, I was probably 12, 13 years old, who suffered severely from diabetes to the point where she had to have both of her legs amputated. And as a young kid, I mean, that was just horrific, because she ended up having to move into our household, and I became a part of her caregiving team. So my mom's mother. And that just was devastating for me. And I remember like it was yesterday, I was sitting on the side of her bed and I asked her the question, grandmother, why are you suffering like this? What is going on? Why are you having to deal with this? And her answer was, this is God's will for me. And that answer just did not sit well with me as a young kid. And so I always knew I wanted to do something to prevent other people from not understanding that their health behaviors are really the cause. Because my grandmother cooked, just as you all are talking about, the salt, the fat, all those types of things, the way Black grandmothers cook, same thing. And that was really the cause of her issues, but she couldn't recognize that it was God's will. And so that's what propelled me into this area. So I went to, I got a joint PhD from the University of Alabama and the University of Alabama at Birmingham. And I was the only PhD student, Black PhD student in the program. And the other significant thing about that, and many of you have mentioned this, there were no Black professors there during my time. So the whole time I was getting my PhD, never once was in a class with a Black professor. And so that's one of the things that we're trying to do at Moffitt, is to address this whole pipeline issue for Black physicians as well as researchers, because one of the things that we do know is that when people come to a place like Moffitt, they want to see people that look like them. And that's important. They want to see people that look like them. And then the trust issue, the one thing I'll say is that we have to be in the community more. Can you all hear me?
Yes.
Can you still hear me? My earphones are cutting out. We have to be in the community more, not only our physicians and scientists, but our leadership. There's an old saying, don't just come to the community when you want something. Come and be a part of the community so that people can see you, they can talk to you, and they can understand that you really care about who they are as a community.
All right, thank you for that.
Mm-hmm.
Okay, Rose. Why did you go into this particular field?
I was going to say I'm a little humbled because I don't have the credentials that everyone else has, but I have been in social services since the early 90s. honestly, initially I was a business major in college, and I thought it would make my resume make me look really well-rounded. But once I started volunteering for a local nonprofit, I fell in love and I found my passion. And by the grace of God, I haven't looked back. I've been employed in nonprofits ever since. But my motto has always been that I'd like to be able to work myself out of a job. I wish we weren't necessary. And it is in regards to engaging people in a change in lifestyle, right? So I pretty much agree with everything that everyone has said. We just need to really immerse ourselves within our own communities, be very consistent, be very visible, be the leaders that we are called to be within our own communities. I am 56, and so I am of the school of militant advocacy. And so I'm very much about being in the streets. And
And is that how you build the trust with the people?
Absolutely. Absolutely. I feel that people who are, especially people who are from marginalized communities, can smell BS, and they know if you're being sincere or not. And so sincerity will go a long way to build that rapport, and that's necessary to get people into a continuum of care and get them, to retain into a system of care.
Thank you for that. Hey, Dr. Michael Oceansami.
Yeah. So I didn't really have that issue again with some of our panelists had mentioned before about going to an HBCU. I went to Meharry Medical College, which is again an HBCU, so I didn't really have that issue. And then I went on to training for anesthesiology at UAB in Birmingham, which Dr. Green had some training there too as well. Nice institution, but again, I myself was, I think, one of 83 or so residents at the time. So it was difficult kind of navigating that space. And again, I had also a lot of my patients look like me. So it was important for me to educate not only my colleagues, but my superiors about some of their implicit biases that they kind of had before I left. So I made that one of my priorities before I left. In terms of trust and the doctor-patient relationship in our communities, I think everybody has said all the right things in terms of being visible. We know where our people are. They're in the churches, they're in the barbershops and the hair salons, so we need to meet them where they are, because they don't know that we exist a lot of times. Some of my patients, I see them, on the morning of surgery, and they'll pull me to the side and be like, I'm happy that, I see myself in you. You're going to be taking care of me. I mean, because putting somebody to sleep, sometimes these patients don't wake up. So, when they see me, they're a lot more relaxed. So I think we know what we need to do. We need to be in the community. We need to be in the churches. We need to be, be where our people are, so that they can see us and know that we're out there. So.
Thank you. Thank you for your comments. Dr. Andrews Collins.
Very similar to what he just said. I also went to Meharry. I went to a HBCU for undergrad and to Meharry.
Okay.
And one thing I liked about that situation is that you couldn't use your race as an excuse. And because everybody there looked just like you. So if the nurses were mean to you or the attending was mean to you, you couldn't say it was because you were African American.
Okay.
When I went to the University of Arkansas for my residency, it was a different story, because like others who went outside of the HBCU for their training, it was very strange because I was the first African American OB-GYN resident that they had in 25 years.
Wow.
So when I went on the floor, most people thought that I was either in housekeeping or something like that, but they didn't think that I was the person that they had just paged saying, we need the resident to come up here and see this lady. And when I got on the floor, even the African American nurses would go, who are you? Like, where'd you come from? But I ran the residency program there. I mean, I was there for 27 years. I ran the residency program for 10 or 12 years. And it was very hard to get African-American residents voted in.
Wow.
Because my vote only counted for one. And we did have one other attending that was from UAPB, who was our director of gen oncology for maybe 10 years. And between me and him, we really still only had 2 votes. And probably in the time that I was there, that whole 27 years, we probably had 5 or 6 African-American residents. But I mean, they had to be at the top of their game for them to get put high on the list. So my experience is, I loved doing what I did. And just to let you know about the whole cell phone thing, I would also tell my patients, if you abuse my cell phone number, I will block you. I will block your number, and don't think I'm not serious with you. But I agree with what he just said, is that you do have to go when they see you at church and you go to the same beauty shop, and you're out in the community. It does make a huge difference for trust, because they believe that you're in the system. And that's really all I have to say about that.
Well,
Thank you.
Thank you for your comments. And last but certainly not least, Dr. Jamia. It's Jamia. Jamia. Oh, it is. I was right the first time. Okay. Ocean Sami, same question for you.
Yeah, and so like Dr. Collins and Mike, I also attended Meharry Medical College. So one of the best decisions I ever made, because that is an HBCU, and there was never a time that I felt like I was lacking. There was encouragement, inspiration all around me. So I didn't really have issues in that regards with medical school. However, I did go train in Cleveland, Ohio at Case Western for my internal medicine. And currently I'm at USF Tampa General doing my advanced heart failure fellowship. And so, of course, those not being HBCUs, the experiences are different. Had the same experience as Dr. Collins, being called to see a patient, someone sees me, they don't take me serious, or they don't think I'm a physician. I could walk in a room, my white coat long, just like everyone else, white coat, but somehow they'll pick me out and ask me, am I the student or I'm the nurse? No offenses to any nurse or anything, but it was just like, who are you? You can't be the doctor. And so, I mean, after a while, you experience that and you learn how to deal with it, in a professional manner. So for that, I think, like you said before, that's why representation matters. Because, and the funny thing is, like Dr. Collins said, there would be sometimes Black people who would not even really realize who I was. They would think I was something else or whatever, doing something else as in my profession, and not really consider me or think that I'm actually the physician. So I think we still have a long ways to go in that aspect. For me, I enjoyed cardiology. I decided that I wanted to be a cardiologist when I was in medical school at Meharry. We had opportunities to kind of like rotate through different areas. And that was the only specialty that kind of like caught my attention as far as me being interested. And so once I kind of decided in medical school, then I kind of set myself up during residency to make sure that I matched in cardiology fellowship. So I was fortunate in that regard. I think a lot of things that were discussed as far as the patient and doctor relationship, a lot of the panelists hit it on the head for the most part. But one thing that I try to be cognizant of, and I'm still working on this, I always try to remember one unique thing about the patient. So whether it's a hobby, maybe someone that's significant to him or her, I think that's one way to connect, because at that point, I mean, I know that I'm here as your physician to treat you for a medical reason, but when you start to remember the little things about patients and then you bring them up, like the next time you see them or the next time you see them in clinic, it's amazing how they react to you. And even you can see the delight in their faces. You know, if I'm talking to Mr. Johnson and let's say I met him 2 weeks ago in the hospital and we start talking about golf, and then I see him 2 weeks later in the clinic and I'm just, you know, I say something like, oh, how was golfing? You remember that? Yeah, we had a whole conversation about it, you know? So that brings another level of trust, a familiarity with your patients that I feel like they really appreciate. So I think that's one way to connect with your patients, because that would take you a long ways as far as like getting them to be compliant and do things that they need to do so they can become healthier. So
well, thank you for your comments, and thank you all again for being here. I know this is Power Hour, but we pushed through Power Hour and a half. I knew it was going to be long, but I'm telling you right now, everyone is just in the chat saying how great this information is. I'm getting text messages how wonderful this information is. So I thank you all for your expertise and your time tonight. I do, before you hang up, I want to get a picture, so make sure you don't log off right away. But next week, we're going to finalize our Black History Month health and wellness, and we're going to be talking about diet, weight, exercise, obesity, those things that plague our community, the same things that we're talking about today. So we're going to have a nutritionist and some trainers on the line to talk about what can we do in our community to help get healthy, so that like Rose said, work your way out of a job. I'm not trying to work you all the way, but you know, work your way out of a job so we can get our community healthier. But so thank you so much. Dr. Lewis, do you have any last words?
I would just like to say what a really, really robust and informational session this was tonight. I'm just like Ms. Fullwood. I was getting texts saying, oh my God, I'm learning so much from this. This is really helpful. So we want to thank each one of you for your expertise in sharing. And I certainly hope that we don't have to wait until we have another Black History Month to bring you all back on. We do offer Power Hour throughout the year because I think there's so much information that you all shared that we can certainly do some continuations, because not only do we do Black History Spotlights during the month of February, but we do them year round. It is called our Black History and Heritage Project, and that's led by Ms. Angela Forward and Henry Washington Jr. So I thank you all. And to our participants, we thank you all for joining us again for this very informational session tonight.
Ready for the picture?
Yes, hold up.